but I am Averjill with Lacey. And this is my partner, Angela Daniel, and we're happy to be able to have this space and time to present to you about some work we're doing in regards to doula integration, what that looks like, feels like, what the process is. All right, next slide. We want you to say what's on your mind. Make sure we want this to be an interactive experience. We want you all to engage. So whether that means, putting a question in the chat, we'll definitely have a Q&A. So you feel free to raise your hand when we open up the Q&A. But if you want to enter a chat, I don't know if Andrea, you can keep track of any questions, or do we have the questions open? I didn't think about that. But ask them, and we'll try to capture that if we don't raise your hand. But we want you to say the thing, the pink elephant in the room. We want to discuss it and be open. So as I said, my name is Averjill, work with Lacey. I've been a doula since 2015, and I like to say my former life is in that of hospital administration consulting and then benefits management. So I get to use both sides of my passions to combine in the space that we are in now. Angela?
Hey everybody, I'm Angela Daniel. I'm coming physically from Gainesville, Florida. I've been a doula for a little over 16 years, and in my former life, I have a master's in macro level social work. And so this has really been a fantastic blend of being able to pull together all of the work that I love doing and really coming at this field with that lens of a social worker. And so really grateful to be in this space today and share with you a little bit about our story and the work that we're doing. So thank you guys for being here.
Wow, I see someone from Boynton Beach. Hello, we're neighbors. And we're going to ask you some questions. If you're on a screen and you're able to participate via your phone, or you have your phone up to your screen, we'd love to know, if you have given birth, did you have the support of a doula? Okay, that was 50-50.
Well, that's pretty fantastic. Oh, nice. It's moving now. I always love watching it as people get to come in and get access to it.
And I find this to be true. A lot of people have had children at a time. We're in this maternal health space, but at the time when babies were had, you didn't know that this was available to you or how to even reach out to one. So we hope that as children continue to be born, that people know that doulas are available to them, and those doulas have access to wherever you happen to give birth.
I love that we don't have any what's that's. I mean, that might be a first for us.
Well,
So
yeah.
that's fantastic in and of itself. I love it.
So outside of having a doula for personal reasons, you having a baby, have you in the work that you do, have to work with doulas, whether it be administratively, they're in the hospital with you, you're a midwife, or you train them? Okay, so a large piece of you didn't have the chance to use a doula, but you have been working with doulas. Grace, I think it's right. It is natural work without the title, but the work cannot be sustained that way, right? So we have to make a way. Because I would say you're a doula before you're a doula. Okay, thank you.
So I'm going to share a little bit of ways we get started with our time today, just kind of about where this all came from, right? And how Averjill and I actually met and started on this journey together. And like so many of you guys, this pandemic that we had, gosh, which has been so long ago now, it feels like, when the world shut down in one day. And so in the state of Florida, Averjill and I both live in different areas of the state of Florida. We had a large group of leadership getting together to really figure out what we needed to do to get doulas back into the hospital. And so the more we worked together, the more we kept seeing each other in meetings across the country. Averjill and I both again wear lots of different hats, like so many of us do. And we would be in meetings in New York and in Georgia and in Texas and in California and talking about doulas and doula work and what's happening in the landscape. And so we really realized as we were looking through what was happening in our own areas, that it wasn't about just getting back in to the hospitals because that was happening to different degrees and different hoops were needing to be jumped through and all these things happened. So we started connecting with change agents that are really champions for doula support and doula work. And out of that, developed this Doula Friendly Initiative to really go in and work with hospitals on how to work with and approach doula care and doula support and really understand and integrate it and see the value of doula support. At the time that we're doing all of this work, were being discussed and talked about even more. So we really wanted to kind of bridge that gap of what it looks like to be training more doulas and also being able to work in hospital spaces.
So, what is a doula? I'm glad to see that nobody was unfamiliar with the word but just in case you weren't, brave enough to speak out, doulas are non-medical support for the birthing person throughout the entire perinatal period. So, what is the spectrum of doula care? I think most people just know about birth doulas, and now postpartum doulas are becoming a little bit more popular or platformed. But there are fertility and preconception doulas, of which I am one, termination of pregnancy, miscarriage, birth, postpartum, bereavement. And what are we doing when we are providing this non-medical support? There's physical support, so we're actually getting down with you, squeezing hips and all the things that people think of and see. But there is a great deal of emotional support that we provide, and it's not just for that birthing person. I like to say that, we're the doulas for the partners too, right? And in some cases, depending on the family structure, the children, dealing with what is this, what's going on with mommy, you know, um, siblings, what's that? So we fit in where we need to be for emotional support, educational support. What does that look like? Prenatal education, but education through the whole way, especially for first time parents and for people that have experienced trauma in previous births. That really comes to the front of what is provided by the doula. Like I said, partner support and advocacy. And when I say the word advocacy, people in hospitals become a little shaky and nervous. What does that look like? We are never here to necessarily speak for their patients, but we're able to help that patient find their voice, ask the questions that are important to them, remind them that if they don't understand something, they can explain it, or we kind of lead that conversation. So advocacy looks a million different types of ways, but that is part of the work that the doulas provide.
Really grateful, like we said earlier, that there is a lot of discussion around doulas right now. I want to make sure very, very clear in this space and every space that we talk in that while we're grateful that doulas are being discussed, we're grateful we're investing in doulas and the doula workforce. Doulas are not going to fix the maternal health crisis that's happening right now. Doulas are one piece of this entire puzzle. And what I appreciate and value one of the many things is that the research that's continuing to pour out is pointing to the same types of things. Those that have doulas for first time moms have a 40% less chance of having a primary cesarean section. Their labor time, it tends to be shorter. They're expressing higher satisfaction with their birth experiences. Their baby's APGAR scores are a little bit higher. Now we're actually seeing with our Medicaid population, because at this point in time, we have a larger amount of Medicaid coverage, that 46% of those that were a part of one recent study were more likely to attend their postpartum visits because their doulas were able to remind and encourage them to get into that postpartum follow-up with their provider. So we're continuing to see more studies being done in the birth doula support, and there's also several that are currently being conducted looking at traditional postpartum support as well. So hopefully just kind of continue to, again, grow and build the evidence and the ways that doulas can impact and influence the maternal health sphere, which is exciting. If anybody wants to earmark this page, this is the National Medicaid Health Law. They keep track of what is happening. If you would like to know what is happening in your state with Medicaid, currently right now, I think our most recent map after this legislative session is we have now near up to 30 states that are in some level of reimbursement. Some of them have been doing it longer than others. We have a few that are going to be gearing up to do reimbursement for Medicaid. But with this, and we changes in Medicaid, we also see changes in private insurance. And so Anthem is starting to cover doulas. United Healthcare recently announced that anyone that is carrying their coverage, they will also cover doula coverage for their private paying clients. And so there's a lot of different avenues now for doulas to actually get access to, or for folks to get access to doulas to be able to cover their doula support. And as we continue to see this being discussed with Medicaid, we also kind of continue to see that expansion grow, and the other ways that doulas are being funded and supported through private insurance and private entities as well.
As we see insurance ramp up in coverage, whether that be Medicaid or private, you're going to see more doulas have an opportunity to practice in hospitals. For those who don't know, doulas can be anywhere babies are born. So whether that be home births, child birth center births, or hospitals. So, and you transfer. So if it's a home birth that now needs to be transferred, or birth center birth that needs to be transferred to the hospital, oftentimes we can go and the midwife can't. And so we are that person that sticks with them the whole time.
And I think that one of the most recent statistics that we saw was that 94% of births happen in hospitals. So even as a doula, when people ask me, Averjill and I both maintain bedside practices, very actively working in our communities. People always ask me, "Oh, are you always at home?" And I was like, "Actually, I spend more time in hospitals than I do at home. That's where more babies are born, right? Like that's where we're more common to be at is in hospitals." And while this landscape and this doula coverage and this access is fantastic, this also means that we're pouring more into training doulas, training community doulas. There's over 180 training organizations at this point in time training doulas. And so again, lots of great work being poured in. But if we're not also working and collaborating with hospitals to be ready to receive those doulas, we're not going to really reach all the outcomes that everybody would like to reach by doing the work that everybody's doing.
Okay, so what's the challenge that we are tackling here? And I think that there are a couple of key stakeholders and they have different challenges. So from the patient perspective, sometimes there's a lack of trust, not having access to doulas in some of their spaces. So if it goes to an OR birth, now this doula that's been with you for 14 hours, you're not able to access them. Or not feeling seen or heard, or worried about that because you're coming in there with a doula, you're one of those type of patients, etc. From the doula perspective, feeling that palpable, not being welcomed as part of the birth team, and also feeling unsafe, it could be triggering for them if they've had experiences in the past, whether helping clients or themselves. Lack of access. So again, not having access to their client wherever they may be within that hospital. And then also have the healthcare facility lens. I can't take off my risk management hat. It is a business and there is risk and liability that has to be accounted for. A lot of times it's just they don't understand what doulas are doing in the space. And so that's the clarity that's being brought to them. Understanding what in the world a doula is there to do, what's their scope, and how does it work with the scope of the people who are already part of the care, recognized as part of the care team. And how can you program for a multidisciplinary approach? How do things flow for that? And with the designation, the intent is solving for all the stakeholders, keeping the community at the center. right? Because it's not just about the hospitals, it's about the communities that those hospitals serve. And so there's no cookie cutter way to become a doula friendly designated hospital, because that hospital in Iowa is different from that hospital in Arkansas, different from that hospital in Alabama. The northern Alabama is different from southern Alabama or one county over. So there is no cookie cutter, check these boxes and you will be designated. It really has to do with, let's start. What are the issues in your community, right? And program from there. So, what does integration even mean when you talk about integration of doulas? It's very intentional that there's a collaboration happening where there's mutual respect between clinical teams and doulas in the community. Um, we often get questions, is this for community doulas? Is this policy and programming for community doulas or doulas within the hospital? So we just say yes. It's doulas. By and large, you're going to have way more community doulas than you are going to have on staff if that's what you have. Um, so we're going in there from doulas, whether you are in the hospital, work for the hospital, or the larger population, which is coming from the community. How will they be treated? How will they maneuver through the system? Access, welcoming doulas to all birth spaces, education. So when we say education, it's for everyone. Co-learning opportunities for both the clinical staff and the doulas. Sometimes it'll be separately, sometimes it'll be together. So we really are big fans of co-learning opportunities where they're side by side, because there's nothing, if we're saying doulas are welcome in the OR and you're a nurse and you've just left training 2 weeks ago with Rebecca, and she walks now into your labor and delivery room or your OR, you can say, oh, hey, Rebecca. It creates relationship, accountability. So, what's that feedback loop? How transparent is it? And a lot of times, you know, it's but from the hospital's lens, it's about what can we do if there is a situation with a doula that we are unhappy with. And there is a grievance process that is worked out, but it also goes in the other direction. So if the doula has grievances, how is that made known in safe ways, in ways that will have a resolution that is communicated to the doula? So we require a full accountability feedback loop and equity, ensuring access for all birthing people. So this is by no means a full picture of what it means to be doula friendly. There are a multitude of bullets under these bullets. But if we kind of take a chunk out of everything, this is what it will look like. Again, programmed for the nuances of the hospital and the community that it serves. So you have to establish a stakeholder committee. Who's on that? Um, Really a cross section of everybody that could come into contact with a doula or the presence of a doula affects, and doulas from the community. So 2 to 3 doulas from the community must be there. If you have doulas on staff, fine. One or two of those can be there as well. But we have nursing leadership, administration leadership, anesthesiology leadership for sure. But then you have communications leadership, because what good is it to do all of this in your hospital and nobody knows, or the community doesn't trust it because nobody's spoken to them? So communication leadership, and everything in between. Again, doulas are not visitors, increased access to their clients. They are welcome in the OR. There is official doula policy that's put into place. Again, we have um, not a template, but we have kind of scaffolding that we set up and then customize based upon, there are certain requirements of said guidelines. For example, the grievance process that we spoke about. but there are nuances that are put into everyone's doula policy. Education plan, so that um, single or co-learning experience. And if there's no data behind it, we know that people don't respect it, right? And you can't prove the numbers that people are looking for. So there is a lot of data that is collected and evaluated. And if I could speak for Angela, if we take data, we are going to report back. So we're not going to have surveys in the communities where your hospitals are and talk to the doulas and everyone else and not have town halls so to report back where they can join and understand, well, this is what the community said, and this is what the hospital said.
And we try really hard just to piggyback on that. Averjill knows that data is my heart. We really try hard to create a space where people feel comfortable talking about the pink elephant in the room. We're asking for people to be willing to invest time and effort and energy in this to make a cultural shift, and all of that starts with assessing where they're at in the very beginning, and making a space where people can say the things that they need to say. I want for an OB to come in the room and say, "I had a doula do this once, and it was horrible." Or a nurse to come in and say, "Oh my gosh, I had a doula here for the OR and this time it was absolutely amazing." So we want to capture all of those stories. I want to go in and hear doulas talk about how amazing the midwives were and how great the nurses are in these hospitals. And so we can balance out that information we're receiving. And then always be prepared to give it back and to share so we can learn and grow. So our goal with our data when it comes to doing that analysis initially is to make sure that we're creating spaces where people feel safe enough to share. Because that's the only way we're going to actually be able to look at what needs to happen to make actual change and keep things moving.
Take that, Angela.
Um, we always love to share this when we're initially talking with people because when we're looking at that stakeholder group and they're like, well, who all needs to be here? Who all do we need to talk to? Why do we need somebody from over in this area at the hospital to come in and talk about doula care? This is just a brief overview and kind of drawback of the areas that the doulas actually touch within a hospital system. So we can be in any of these places. Triage in some places is called OBED. That's admissions where people go when they first get in there. To antepartum for those birthing people that have medical challenges where they have to be in the hospital for an extended period of time. Doulas are often in those spaces. To the anesthesiologists or CRNAs that work and protect an OR space and serve and do anesthesia for laboring and birthing people. And so really the doula is everywhere. And we want to build this in a way where people are not just hearing about a policy at the end, right? Like it's not an effective way typically to move forward when you have an announcement that just says, hey, we have this new policy, everybody just do this new thing. Instead, we want to actually work in the beginning to get everyone's feedback. So we're building a policy or guidelines that serve the purpose and help them feel safe and comfortable moving in this space. And then we have to remember that the doulas are at this table as well, giving their feedback on how it feels to be the one entering the space. How does that doula feel like they're received when they're in antepartum, or how are they received when they've had somebody who's in recovery if they've had a surgical birth? And so all of these spaces really touch the work and the connection with doulas. And so that's why it takes quite a bit of energy and effort to move into the space and to really get the feedback and make sure all those voices are heard. Because then by the time we launch and we have doulas in place or and guidelines that are out there, folks from all these places and champions are already out there telling everybody about it. Oh my gosh, did you know we're doing this work to become doula friendly? And so they're already celebrating it and sharing it with their staff because they've been a part of the process from the very beginning.
So
So, so go ahead, Averjill.
here's another slide up for you. What is a barrier to doula integration from your point of view? So we all have different point of views in here. So whether you're a hospital, a doula, someone working in public health, state agencies, what, and it'll come up here as you all type. What, from your perspective, what is a barrier to doula integration? Provide understanding.
And we see that quite a bit when we're doing our surveys and the works that we've been able to so far. Of lack of reimbursement, yes, or quality reimbursement. Let's put that in there too.
I'm not sure if people on the call know, but like a doula burnout period is 18 months. So a lot of times we see programs pumping money into doula training to expand the workforce. And we are in favor of that. But once they get to work, what are they treated like? Are they being paid fairly? There's a whole slew of things that go beyond just workforce training and expansion.
Yes.
So, and what we focus on is that hospital workplace for a doula. When you get there, are you going to be allowed to do what you came to do?
Yes. Different philosophies, lack of care, lots of references to funding, which is becoming even more challenging now. We went through this heightened phase where we are getting lots of funding for doulas, and now we're kind of in a little bit of a desert, like a lot of folks are experiencing regarding funding. And reimbursement is continuing to be a challenge. And the fact that every single state does something different. So we're also working with doulas that might live on a border of working in two different states and understanding what it is to try and bill and make a livable wage in different areas. Lots and lots of things regarding Medicaid reimbursement. Yes, resources for integration of doulas into other programs, not understanding the work. We do see that question come up quite a bit, actually, from several different lenses. We've had a lot of surveys we've done in several different facilities at this point, and that's one that continues to come across from not just obstetricians, but even we ask everybody to define a doula from some nursing, from anesthesiologists, even from the doula community saying, I don't feel like they understand what we do and what our scope actually is and how we're supposed to work in that space. So we really hear that quite a bit.
And we really build that bridge between the community of doulas doing the work and the hospital. Because a lot of times, from a clinical perspective, they're not sure where doulas fit in. And so there is anxiety when a doula enters the room, a feeling of uncertainty.
I really like this lack of understanding between urban and rural birth needs. That is a very, very beautiful point. I love that. And one of the other things that we're discussing, and this actually can be urban as well as rural, is the amount of deserts that we have happening right now with all of our providers. And that's obstetricians, nurses, midwives, and also doulas. We work in so many places where if you want a doula, they're an hour or so away from you because we don't have the infrastructure to maintain doulas in all areas too. So we also have doula deserts that we're continuing to see. And expectations that come with governance and work. Yes.
A lot of times from postpartum care perspectives, it's because of that postpartum doula or that birth doula that has a couple of postpartum check-ins with mom where they may, that birthing person may think, oh, it's normal. This is normal. I won't even complain. But when asked
Mhm.
by the doula or the doula asks the spouse, like, hey, or the partner, what's going on here? Those are often times where they say, it's worth the drive. I know it's 45 minutes away. I know it's an hour away. This isn't normal. And you have to have your provider check on this. But it's those touch points that sometimes are far sooner than the next time they're scheduled to see a care provider or even want to see a care provider.
Yeah. This is amazing, you guys. Thank you. So we really want to kind of break down a little bit more about what this looks like. And then we're also going to make sure that we save lots of times for just discussion and questions at the end. We want to make sure we hear from you guys and what you're seeing and hearing and feeling in your spaces. Really ultimately what we always come in this space with is, again, it's about the community, it's about the patient. And if we're all doing our pieces to come together, all no matter what, that patient is going to be much better served and receive better care. So what this looks like from a clinical standard, like a lot of you guys have mentioned, is really understanding the role of a doula, and making sure that this clarity is seen across the board, right? Like that doula access. So we don't want it to just be the fact that they see doula Sam come in, who is here all of the time, and everybody time Sam walks in, they're like, "Hey Sam, it's so good to see you. Of course your client's going back to the OR. Of course you can come with us." We need for policies and guidelines to be grounded so that we can get that access across everyone that is coming into that facility, whether you have just trained and are finishing, whether you're just there every few months. There are some cities that are large enough that you may not go to the hospital for another 7 or 8 months. You've been doing active doula work, just not in this hospital. So really looking at how we can build this so that the doula has access and across the board in the various stages of the facility. And one of the things that we continue to hear from our clinical staff is, again, this role back and forth of the influence over the client. And so when we talk about power dynamics in the room and really break down, and we lead through like language lab opportunities and ways to actually break down how communications happen, and then really kind of getting to the base of where that's coming from and what that really looks like, again with the doulas as well as the clinical staff. But those can be some barriers to successes as far as that we're just facing to move through this process. Average, I'll let you take this one.
From an administrative perspective, risk and liability, um, they're looking to assess that and think 40 steps ahead. And one of the things that we, ground them with is doulas are in your hospital right now. They're in your hospital right now. You just can't point them out. You can't quantify how many. And so working, like meeting them where they are, yes, but helping them to understand logistics of space. So that really comes into play when we're talking about the OR. There's often a push and pull of, is there going to be enough room for the partner and the doula? And, what can we do about that? And relationship management, if they don't feel like they have a relationship with um, us, yes, but it's more about the leaders in their community. This will never be sustainable. And sometimes they wouldn't know where to begin on reaching out to leaders in the community, whether that be to have a conversation and you really corral doulas and bring them together, or supporting people like any state programming, the Healthy Starts, et cetera, anybody who's doing training, they really need to build that relationship. And one of the things from an administrative point of view, the risk and liability I want to bring up is, oh, doulas have to show their certification at the door. Not recognizing that for many doula trainings, you have to complete training, then do a number of births before you can ever get your final certification. And in the same way where they have residents and at medical residents at their hospitals, that is the process kind of doulas go through. Or you have that doula that's been practicing since 1977 and has long since not recertified or certified at all, but she knows more than I ever will about birth. And so we stand in the gap to help the hospitals understand what doulas look like as they come to, be a part of the work happening at their hospital. Barriers to sex from a doula perspective, not feeling welcome, feeling like you said this last time, it didn't work out. Do you really know what I do? I don't feel safe. I feel like I'm pushed to the corner. I don't have access to triage. I don't have access to post-surgery, much less surgery at all. So just feeling like this process is actually going to involve them and allow them to do their work. So altogether, we're keeping the patient in the middle, right? So everybody has their role to play, but it's also that those two people being the baby and who birthed the baby could go home happy, healthy, and safe.
And it's a part of the data process. It goes as far as this, building the education and data planning with this. Our goal is ultimately always after the hospital is designated to also be able to go back and revisit with the patient in a very gentle way, whether it's like a 5 questions, like, did you have a doula? Did you feel like your doula was received? Because we also want for the patient to be able to feel the difference and feel like their doula is a part of the team and not where they're feeling and actually we had a lot of tension in our room. And so again, kind of keeping that patient front and center along the way with the work. So things that we wanted to make sure that we realize that are key takeaways from the work that we do and the time that we spend in the space is really setting the table serves a purpose, and taking the time to really bring in stakeholders as a part of that leadership team, even having them switch out. So you have a few different doulas that are coming to the table, then it's also being discussed in the doula community, and it's really building those relationships. So it really is about finding that synergy and finding a way to value each other's roles within that space. And that involves a lot of different levels of education. So we're educating the champions from the very beginning and sharing that data with them so they can start the process of educating their staff. Hey, we're going to do this thing and become doula friendly. I'm learning a little bit more about what doulas do and how we're going to be working together in our space. So that it kind of becomes ingrained in what we do and the work that we're doing. And as we've mentioned before, those co-learning opportunities are really important. It's something that every single survey that we've done, whether it's been with clinicians, whether it's been with doulas from the community, have said, when we have said, what would be like list of the things that are good for you as far as moving in a more positive space within their facilities and that you serve in your community, it's always spending time together outside of being at the births. And so we continue to hear that very, very frequently. So these opportunities are really important for everybody across the board, and really having a policy and a guideline to go back to. We have a lot of people that have want to call it guidelines and then move it to policy because it's easier to change. That looks different per facility, because as you move through a guideline or you have to go through agreements for the first time, all of those things need to have a little bit of wiggle room to be tweaked as you're utilizing all your new systems that you put into place. But it's important to actually go through this process and develop something that can be shared with the public. So if I've just moved to Detroit and I am nervous about going to my first birth in Detroit, and I know this hospital is doula friendly, I can go to a location and find what their guideline is, and know how I'm going to be received and feel confident moving into that space that I'm going to be part of the team at their facility. And that all comes back to this bidirectional accountability. It's an interesting process to work out, but it's near and dear to the core of the work that we do. But it's really, really important piece of this work to really make sure that the doulas also know that they have a voice and that they really understand how they're supposed to be welcomed and received in the space too. So one of the other
So,
things that I'm sorry, go ahead, Averjill.
so we get a lot of questions on, what is it, what are the guidelines? Can I have a copy of the guidelines? Can you send me a template of the guidelines? And we don't have a cookie cutter approach to that. Again, there is a bare minimum. You have to have these aspects. But then through the survey that we do with both the community and the hospital, those things come into play because it helps us understand where the confusion, where the bottleneck is, where the opportunities are, and those things go into the guideline. Because what worked for, hospital 123 sometimes is not an issue or way more inflamed in hospital ABC. And so we really take a look and, reassess after some time, the plan would be. So for formal guidelines, we examine current policies. So we can have this wonderful doula policy, but did you edit the visitors policy to say that doulas are not visitors? They are, part of the team. You get buy-in from that large group we were talking about. That's the OR, folks that run the OR, folks that manage clinicians, manage nursing, antepartum, mother baby, all of those teams. We socialize this again, as Angela said, our horror story or worst case scenario is to pop up with doula guidelines on a Monday, and by and large those who work at that hospital never heard of it. Those folks who are doulas in the community never heard of it. Setting realistic expectations, especially where it comes to access, where it comes to guidelines and escalating that up. Facility-wide standards that everybody, because a lot of times you're working with systems, and so for the north side of the hospital versus the sister hospital on the south side, we need to have facility-wise, unless it's like a pilot and you're trying it out in the north side first before it hits the south side. Plan for attrition. So that's wonderful for everybody who's working at the hospital or a doula when this goes live. But what happens from 6 months from now when this nurse is her first time in labor and delivery? And what does it mean to be working at a doula-friendly designated hospital? Or this doula just finished her training, and so now this is her first time stepping into a hospital. What do I do now? What's expected of me here? And like I said, create a plan for disputes and concerns. And we don't want to just say that the plan is to communicate what's bad. It's also what's to communicate what's good. So those of you who've had terrible experiences as a doula in an OR or trying to get into an OR, and you got into the OR last night, and it could have not gone more beautifully if you could have written the script yourself. We want you to have a place to say that, because that is then supporting the standard that's set.
And one of the things that's important for the facilities that we work with to hear, as far as setting realistic expectations, one of the biggest concerns that we hear is about space in the OR. And if that's the case, that if we need to use OR3 when you're on the floor and you have a doula, because we know that it's big enough and we feel safe enough in it having a space, then we try as much as possible to use OR3. So, but knowing those things in advance can be very helpful. Again, for the doula and for the patient, when we're meeting with anesthesiologists, we again bring it back to the fact that it's not about the doula knowing where they can be. It's about the doula being able to set the standard for their client, for your patient to know what to expect when they walk into your facility. So knowing that if for some reason they end up in a surgical birth, we're going to try to use OR3 because we know OR3 can have everybody there that's a part of your team. And so knowing what those expectations are in advance is really helpful for the patient.
We're going to try to wrap up because we know there's questions that we want to answer, and we want to
Yes.
wrap up your time.
And I feel like we've talked about the this already. So we would love to open up for any questions,
Let me,
discussion. I cannot see the chat.
yeah, let me address some of the questions that came in, and then if I don't catch you, definitely come off of mute and let us know. So there was a question about, let me start from the top. For states actively providing coverage, do they cover all types of doula support? Miscarriage, fertility? No. So if you're talking about Medicaid, um, a lot of times Medicaid is covering like birth, but not postpartum, or postpartum, but not in the traditional sense. So there's a number of different variations. Angela, do you have any to add on that?
Sure. It really depends on what state you're in and understanding how early they'll let you start your visits, and also how you can build those visits. And so it's one of the things that is a continuous advocacy point for folks that are working through states to try and get more coverage. For example, in some states they don't acknowledge just the postpartum certification process. So you have to be a postpartum birth doula, even if you're just interested in working in postpartum, they don't have a way to bill for or acknowledge for that postpartum certification and postpartum time in a way where you could go in and really support a family for 3 and 4 and 5 hours. There are a couple of states that are doing a little bit better at that now. Some states won't don't let you have access to your Medicaid benefits, so you're not able to get them in time to be able to get that if you have a loss and a miscarriage. Otherwise, you could have. But there are some states that are also building that if they have the coverage, and they're there now, you have access to the visits. And so they're now setting more visits that are available for the doula. So I do feel like that's one area where we're going to continue to see change and increase. And I love that competition piece because I feel like it's as one state does this, some of the other states are starting to expand it a little bit more too. And so that's kind of what we're seeing happen as well.
And a little bit about the state. So our first hospital to go live was University of Florida Health in Gainesville, Florida. So that's like an academic hospital. And then there is Jackson Health System is about to go live midsummer, and they are in relationship with the University of Miami, but they are a safety net hospital, right? So completely different. And a few more, brewing in the state, in the Midwest. And I see some of our partners and folks that we're getting to know in Mississippi and Alabama has joined the call. So another thing, which is why there is no cookie cutter, because we have to make allowances for what your state is allowing, right? So, and this is an ever changing situation. Just because it is what it is today, it could be absolutely different tomorrow for your state. Next question, outside agencies violating the rights of the birth in a hospital setting, even while your doula is there. When does
Mhm.
the care actually start during birth and post or before, during, and post? I'm not sure that I understand the entirety of that question for that last piece. Whenever it is in the hospital, because we're speaking about specifically hospital births, a doula should be able to jump in and do whatever is required there. So there's work that's done before you even step a foot in a hospital, months or weeks before your client ever goes into labor, right? There's education, support, all kinds of things. And then there's the hospital, and depending upon what type of support that specific doula provides, there may be postpartum check-ins. Anything you'd add to that, Angela?
No, I think that was fantastic.
Is there an entity that designates hospitals as doula friendly? So I'm going to wrap this into another question that asks about, I guess, competition in the space of the work that's going on in New York and the work that's going on with other entities. I'm not finding that, but so again, we can't stop any any competitors that may come up in the space. For certain states, they may be wanting to stay in their city, in their state, just like
Mhm.
there are certain rules around doulas. Like some states require that doulas, like Angela was saying, you are a birth and postpartum doula in order to be certified with the state. So there are things that nuances that are happening in certain states, and you know, hospitals can and organizations can choose to back that particular state. But we definitely want to be our goal is to be in all 50 states, regardless of where we're based or what the rules in that particular state are. Hope that helps. But what a hospital gets when they go through the process with us is they're deemed a doula friendly designated hospital. Do doulas have a union? No. Not that we know of yet. You know, you may have different training organizations treat alumna differently. So it might be a very close knit and they have meetings. Others we've trained and we don't really see you again. So like Angela said, there's 180 that we can count training organizations in the US right now. Um, Does somebody want to come off of mic and ask their question while I get to find my place in the new question? What about a pipeline from doula to midwifery? We love it. I mean, we love doulas, we love midwives. As a doula, again, we are anywhere babies can be born. So if being a doula, somehow you turn around and you're in love, you become in love with midwifery or nursing or obstetrics, we love that for you because now there's someone in that midwifery position where you're in the hospital or out the hospital, or an obstetric, a medical doctor who is an obstetrician who started as a doula. How lovely is that? They're never going to fight a doula being in that space. They understand it. Leah?
Hi. Thank you both for all of this work and this advocacy and everything that y'all have put together. This has been really great. And y'all have so many great questions that came from your presentation because people are excited about doulas. So that's exciting. Um, my question, it sounds like with the Doula Friendly Initiative, a lot of y'all's focus is in the hospital, but it's integrating doula services throughout healthcare teams. So I'm wondering if you all, here in Arkansas, I've kind of worked on a different approach. We have some great partners that are working on integrating doulas into the hospitals and bringing, the doulas in as team members. But I'm really hoping to kind of do the same thing, but with more of like the pregnancy clinics, grassroots organizations, those community-based places where moms are already going for their care, even like the health clinics, where the hubs where moms are already going for care before they get to the hospital. So I'm wondering if y'all have done any of that work, if y'all have any advice, or if I could reach out to y'all.
The
You
reason
can always reach out to us for sure.
that
Um,
answer to that is absolutely yes. When I say community, it's encompassed of all of those things because yes, the birth may be the Super Bowl of it all, but training was happening way before that person went into labor, right? And so if they don't know, because the whole point is, yes, we are working with the hospital, but part of working as the hospital is mandating that they work with the community. If that is not the case, they cannot be doula friendly. If you don't know who's running your programs in your city, if you're not welcoming them to the table, um, you those organizations that you mentioned, there should be some representatives of them at the table. And yes, we don't need to take up everybody's time where you're at every single meeting, but there are some meetings that it is imperative for you to hear that. And that's why the first step when we start with a hospital is surveying the community and then surveying the hospital and telling both sides what each other said. It's safe, nobody will be identified, but we want you to say the thing, no matter how uncomfortable it is. Do you add
we
to
also want to encourage any of the facilities that we're working with have a wide net depending on the type of facility they are. And so if they have federally qualified health centers that are feeding into them, we want for all of those places to be letting people know about doulas and what they are and how they can access them. And so those community touch points are foundational to what we need to do.
Thank you.
There was a question in the chat about like a doula in the hospital when it relates to DCFS or police or anything like that. Advocacy is part of the work that we do. That looks differently in each situation. But I can promise you, if everybody, because part of this is the security guard should know what doulas are and who that you shouldn't be fighting with the security guard to get upstairs to your client, right? And so if everybody in that hospital knows what a doula is and what a doula does and the access a doula should have, certain friction points are way less likely to happen, or at least asking you to leave the situation are a lot less likely to happen because you are part of the care team. In the same way they wouldn't kick a nurse out of a room, that doula wouldn't be kicked out of the room. There was a hand and we lost it. If you want to
It
come
was
off.
me. Yes. My question. Hi, everyone. Thank you for putting this event together. And one of the question I have is around. I'm not sure. Again, this is an uninformed question. Are doulas allowed to get any type of financial assistance to going through the program? And roughly, how much is a program for you to become, to be able to actually be certified as a doula and be able to do your job? I understand that there's all these other things in place, but before you experience burnout, until you're still excited about this, what is the cost associated with it, and how are doulas currently navigating those systems to become educated?
I would never be able to answer that question in its entirety because you can be trained for free in some organizations. That could be in your city or online. Or there could be a cost associated with it. That could be anything from, a low couple $100 to over $1,000. You may have to recertify with your organization every year or every 3 years or anything in between. And some you paid your money, you're a doula, and as far as we're concerned, you're a doula forever for whoever trained you. So I would love for you to do the research first in your area and then expand the search from there. But you can become a doula in many different ways. like I was saying, there's a lot of money being poured, or there was a lot of money being poured into doula workforce expansion, but not always. Now that you're trained, what do you do? Because there's a myriad of places where you can practice outside of the hospital. And so your training should prepare you for that. It's not just the hospital.
Yeah, no, my question is because I was thinking about, I'm in philanthropy, and one of our partners manages scholarships. So I was thinking about proposing the creation of a scholarship for doulas and midwives. Um, but I was just trying to understand more of like how it works.
Well, we all
Would you think it's a good idea?
Oh, you're never going to hear an argument for me for that. For both, we need midwifery, and because yes, hospital births are what happen by and large, but midwives need to be funded, and in some states you can't practice midwifery, and so that's a whole nother thing that you could be educated on. But for doulas and midwives, there is a large runway to accept funding. I would just like for you to, if you want to contact us, that's fine, to get in contact with the right organizations, whether that be community or teaching, in order to get those opportunities out. And right now we are focused on everybody, but we have a special love for the 5 states in the 5-state initiative with NCIT. So that's Arkansas, Mississippi, Alabama, Texas, and Florida. We are absolutely working with hospitals outside of that, but we want to pour a lot of energy, time, and if comes funds into making that happen in those 5 states specifically. Cortez.
Good afternoon, everyone. To the Doula Friendly co-workers, co-founders, thank you all so much for this. So I'm going to give my personal testimony, and they did not pay me to do this. So I'm in the state of Florida, and we have been working with the organization, the Doula Friendly Initiative, recently since they started doing their work down in Miami. But I can say that we have known Averjill for years. And her co-founder, I am blessed to now know her as well. And so what they're doing is amazing and it's necessary, okay? So just let me help y'all understand something. To become a doula, you need to figure that out in the area in which you live, right? I do work for an organization. I am a certified birth justice doula, and that's what we do. I drop the website. I'll drop my email if you all want to ask questions. Our doula certification program is 18 months. Okay. Some doula programs are 4 days, Friday, Saturday, Sunday, Monday. Some doula programs are online. We're kind of hybrid. We're doing them both. But what I can say, this initiative that the Doula Friendly organization is doing is so necessary. And we've had some talks offline, but just hearing what I'm hearing today really brings it all in together for me. Because I'm one of those doulas that was certified, that was placed in a hospital, and a lot of harm occurred. And so you need to research that area in which you live in. You need to know how you want to practice as a doula. And really, it's on you because doulas are not regulated in states. Okay. And we're in the state of Florida. We don't want regulation. We just want recognition because we know some doulas are traditional. Some doulas have gone through a year and a half of schooling. So we just don't want that barrier for anyone. And then secondly, midwives, yes, bring on the money, all right? That's what we're looking for. Our doula program is free. Shout that out. It's free to the participants, but it costs somebody something, okay? And then secondly, I think someone asked about the doula to midwifery pipeline. I don't know of a doula to midwifery pipeline, but you can make your own, right? Because I'm one of those people that came into the doula field as a registered nurse already, that is going to go back to become a certified nurse midwife. So that's the way I'm using my nursing license and my nursing degree to become a certified nurse midwife. But you have the traditional midwives, you have the CPMs, you have the LMs. It all depends on the laws within your state. So I just want to drop that there, and I want to say hello to my friends, Angela and Averjill. Thank y'all so much and appreciate it.
Thanks, Cortez. I know we are at time. So I'm so happy. We are so happy that you took time to join today. If you have any questions, you can reach us at hello@doulafriendly.com, and we will be happy to address what your concern is. Thank you, everyone.